presentation. It's not allowed in Canada, but I love France. So I'm Reebye, as you know, and this is my colleague Heather Finlayson, and together we'll be talking about the role of perioperative botulinum toxin A in neuro-orthopedics. And this is where we practice at GF Strong Rehab Center in Vancouver, also the UBC Center, and the ICOR, the International Collaboration on Repair Discoveries in Vancouver. Our disclosures. So our objectives today are to outline the perioperative use of botulinum toxin A in surgical and neuro-orthopedic literature, to understand the rationale for perioperative use of botulinum toxin as an adjunct in neuro-orthopedics, and also to outline the findings of our systematic review on current evidence for use of perioperative toxin for limb spasticity. And at the end, just briefly talk about the research of a Canadian perioperative survey that we're doing in Canada, but we would like to also do it internationally with the SNOV group. So when we look at perioperative injection of toxin in neuroorthopedics, we're considering botulinum toxin as an adjunct to surgical procedures. We're also looking at perioperative, the definition being prior to, up to a month, or at the time of surgery. The rationale is that an intramuscular injection of toxin prior to or at the time of surgery may improve surgical outcomes. So let's look at some of the surgical applications in literature outside the neuroorthopedic field first. Interestingly, there are many articles on abdominal wall closure for large abdominal wall hernias. So if patients have high BMI or very complex incisional ventral hernias, the literature has shown that they inject up to 10 days to 2 weeks before of toxin so that the muscle can actually become weaker, and they can oppose it during surgery so they can get a better closure rather than doing more radical surgery. In ophthalmology, we have extraocular muscle disorders like sixth nerve palsy, and what they do is injecting botulinum toxin in the medial rectus, followed by transposition of the superior and inferior rectus muscle, again to weaken the muscle so you can have a better position of the transposed muscle. And also in hemorrhoidectomy, for patients who are having pain with hemorrhoids, they actually inject intraoperative injection of 20 units of botulinum into the internal rectal sphincter. And this has avoided traditional treatments such as internal sphincterectomy and anal dilatation that can cause fecal incontinence. And again, it can also help pain. So 2 weeks prior or intraoperative, they inject the toxin, and this can reduce pain or and also give better outcomes from surgery. Now I'll move on to the neuro-orthopedic area, and it's been used for surgical, reducing surgical movement to allow surgery. So for example, someone with cervical dystonia or spasticity requiring hip arthroplasty, it can reduce and give better effect and better positioning for our surgical colleagues. So I'm going to describe some of the literature. So let's look at the first case ever described in literature for the use of botulinum toxin as perioperative adjunct. It was actually in movement disorder, and it was by Gasser et al. In 1991. And they described this one patient having rotator cuff surgery from severe levodopa-induced dyskinesia and right shoulder dystonia. This patient had rupture of the right rotator cuff and biceps tendon, and he required 3 surgical procedures, but they were not successful because of re-rupture within 12 weeks of each surgery. They then decided to inject 200 units of abobotulinum toxin A to the right supraspinatus and infraspinatus, and 600 units to deltoid. Weakness developed within 7 days, and surgery was performed after 2 weeks, and the results were positive results with healing and good functional recovery. The second article that was published in literature in 1992 by Trainless et al. Looked at patients with cervical dystonia developing cervical myelopathies that required decompression. Because of the head movement, it was difficult for them to do the fusions or decompressions. So they treated these 2 patients with botulinum toxin perioperatively to reduce dystonic movements and allow for successful immobilization. The injections were done 2 weeks prior to the procedure. Both cases had fusions that were successful and no post-operative complications. An interesting one that was published by Adler et al. Is showing you how toxin can be useful to help our surgical colleagues in stabilizing of the neck. This is a 38-year-old with Tourette's syndrome. He had violent cervical tics with severe neck flexion and extension. At age 27, developed a herniated disc at C6, C7 with resultant spinal cord compression. They did a decompression, but the tics were so bad that he had progression of his myelopathy. They then did a C7 to T1 fusion, but that fusion broke, And in fact, he had a fracture periprosthetically. And then they decided, okay, last time let's try to operate again. They injected onabotulinum 40 units into sternocleidomastoid, 45 units into splenius capitis and trapezius bilaterally, and these injections induced reduction in the tics and also allowed for successful head immobilization and postoperative fusion. So how can we use toxin as an adjunct? We can use it for prevention of deformity, prevention of contracture, prevention of joint dislocation, pre-surgical diagnostic tool, and ease of surgical intervention. But what I'm going to talk about now is more how to decrease perioperative and post-operative complications. So during the operation and post-op, for example, tendon rupture after tendon lengthening, tendon transfers, or tendon repair. And most of the literature is on Achilles tendon injuries, and the orthopedic surgeons have done many animal studies, and I'll be describing some now. One of the novel and very nicely designed study by Sandeep Manava et al. From Wake Forest University in the US did a very nice study. They used cute little rats and mice, and I got this from the internet. It's a 30M CD1 mice. It looks exactly like the one on the screen. And what they did is that they randomly randomized two legs. One was a group of mice that were injected with toxin, and one with normal saline in the medial and lateral head of the left gastrocnemius complex. They used 3 units per kilogram of onabotulinum toxin. The outcome in the the mice that were injected 1 week post-op, they showed decrease in maximal single twitch amplitude, decreased tetanic amplitude, and decreased peak passive properties of muscle tendon unit, and decreased injected muscle tendon unit stiffness. What does that mean? It meant that you could maneuver and move the tendon more elegantly, so that could help you during a surgical procedure. It also decreased the risk of tendon ruptures by decreasing the tetanic amplitude and twitch amplitude. Another very novel study looked at, let's do one more. Let's operate on these mice. Let's induce an Achilles tendon rupture. So what they did, they took 79 Sprague dolly rats, as pictured here, and they intervened with injecting 6 units per kilogram of onabotulinum in 37 of these rats in one leg, and the control was normal saline. And they injected in the gastrocnemius muscle, and they didn't specify which head of the gastroc. The procedure was an Achilles tendon being incised and repaired, and also sutured. And then they did an ankle stabilization of the operated leg. So what they did a very nice procedure called the modified Kessler method, using a 2-strand coarse suture with a running epi-tenon repair. And they did this for all the rats. What they showed was very interesting, and if you look at the picture on A, which is on my right, this is a normal tendon. B is a tendon that was injected, muscle tendon complex injected with onabotulinum, and C, muscle tendon complex injected with normal saline. And what they showed is that the tension of the muscle was more in the normal saline population, and you can see that the suture has dehisced compared to the suture remaining in place in the picture B. And their hypothesis is that the tetanic force capability injected in the muscles with botulinum toxin was 5 to 10 times less than the force required to rupture the tendon for as long as 4 weeks post-tendon repair. And then spontaneous tendon rupture rate in the toxin group was 3 times lower than in saline group. And they've seen that many of the rats were showing the picture as we see in C, where the suture was being dehisced because of increased tension force. And interestingly, for 1 to 3 weeks, the tendon rupture force was significantly higher in botulinum toxin group between 1 and 3 weeks after repair, meaning you needed much more force to actually tear the tendon. So how does this translate from knowledge from the animal to the human? Well, botulinum toxin in these animal studies have shown that it decreases muscle tendon stiffness. So this may allow more ease of surgical manipulation for our surgical colleagues and get a better position intraoperatively that may lead to better post-operative outcomes. There's also increase in tendon rupture force. So you need more force to actually tear the tendon if you inject toxin preoperatively. So this could be important for the concept of bioprotection. So could we protect that tendon muscle junction so we can have better outcomes post-surgery? And also, the temporary decrease of active muscle tension forces produced by perioperative toxin can be, again, better for active motion and in some studies shown that it could be better for early rehabilitation and motion of the limb post-operatively. So I'd like to move to describing a few cases, and my colleague, Dr. Heather Finlayson, will talk about two cases that really changed the way that we practice and think about perioperative toxin in our patient pool.
Thanks, Rajiv. So my job is very easy, which is good after some wine at lunch. I'm just going to talk about a couple of cases. The first is of a 62-year-old woman who had a completely non-functional left upper limb. She had a kind of unusual background history where she had tuberculosis or TB, meningitis, and also a stroke 4 years before we saw her. And she really had spastic dystonia of her upper limb. When we saw her, she was referred because of pain and spasm in her left hand with clawing of her hand. In the past, she'd had some treatment, including physio, acupuncture, oral medications, botulinum toxin injections. None of that was effective. She had seen a surgeon in the past who said, quite understandably, that surgery was not an option for her. And then we saw her back in 2010. And this is one snapshot of what her hand looked like. It was very dynamic though, but essentially she had very pronounced extension at the MCP joints and a lot of flexion at the IP joints. And it was extremely painful for her. And as I said, completely non-functional. So we did offer her repeat botulinum toxin injections with the goal first of just decreasing the pain level in her hand from 8 to 10 down to 2 out of 10 or better. To decrease her pain from 6 to 4 out of 10 or better, and also just to relax the posturing severity of her hand. So we did multiple injections, starting with FDS, FPL, and extensor digitorum communis, and tried multiple different injection protocols. We were able to get her pain levels down, but really the function didn't change. So even though the pain diminished, she still had this severe clawing and posturing, and it was continued to be a non-functional hand. Splinting was impossible just because of the severity of her tone. So in 2014, we did a combined clinic with one of the upper limb surgeons who works with us. This was Dr. Tom Getz, who some of you may have met. And he thought she would be a surgical candidate. He was willing to give it a try with the goal of improving the positioning of her hand. So in 2014, he took her to surgery, and he did multiple procedures in the hand. He harvested palmaris longus and a section of the ECRB. He did 5 tendon transfers altogether, corrected a boutonniere deformity, and the plan was for her to be in a splint for 3 weeks and then just a night splint. But unfortunately, after the surgery, she had very severe pain, and about a week after surgery, she just completely broke out of the splint and tore all of the transfers. So she was obviously very upset, but I think even more so, Tom was devastated. So he took her back, so this is 10 days after the first surgery, to do a revision of the surgical repair. And at this time, he did intraoperative injections of botulinum toxin. So he injected the extensor digitorum communis and flexor digitorum superficialis while he was in the surgery. So if you remember what her pre-op hand looked like, extremely extended at the MCP joints, severely flexed at the IP joints. She got a reasonable post-operative result, dramatically better than she was. She got a quite nice opening up of the hand and a really nice functional gain. So she was actually able to use the hand. She could get a key and a pincher grip. She could even start to do some sewing. She was able to decrease her oral medications, and basically ended up very happy with this procedure, and we were able to get rid of her as a patient. So a second, just briefly study, this is a 62-year-old woman with a history of incomplete spinal cord injury, so a C6AISC level of spinal cord injury. She also had a history of severe osteoarthritis with a lot of hip pain, and so she was going to go for a right total hip replacement surgery. The reason we were mostly seeing her for spasticity management was that she had a lot of hip adductor tone with scissoring. So that was probably contributing to the pain from her osteoarthritis. But when she was going for a hip replacement, there was a significant concern that her hip adductor tone was going to affect her post-operative healing. So if you recall the hip precautions after hip replacement surgery, people cannot adduct past midline. So we spoke with the surgeon and came up with a plan that prior to the surgery, we would do botulinum toxin injections to the hip adductor muscles with the goal partly to reduce her post-operative pain, but also to help her maintain the hip precautions. Long story short, it was a very successful outcome. She had no issue with her post-operative healing, no problem with the hip precautions. She's going to get the contralateral side done, and the plan is to repeat the same process. So we certainly feel that botulinum toxin injections can have a role to improve post-operative outcomes. As Rajiv talked about, there is this potential improvement on the muscle tendon unit, so pre or intraoperative injections can help with that manipulation. They may help to reduce the risk of rupturing after tendon surgeries and also to reduce pain after surgery. So in people with spasticity, we know that spasticity is a sensory motor process. So of course, pain has a very important role in amplifying the spastic response. So if toxin injections can improve that, that may also help surgical outcomes. And in one particular case, we've talked about how it may also help to reduce the risk of joint dislocation after a surgery.
So what is the evidence? That made us think. So we started with 2 cases about almost 8 years ago, and then made us realize, well, we should be making a little bit more headway research-wise. So we designed a systematic review for perioperative toxin to improve surgical outcome post-spastic surgery. So we wanted to look at all the literature in all languages with regards to perioperative toxin use. Our inclusion criteria, as I said, any clinical study, humans with limb spasticity. We didn't include rats, just for the 2 rat studies is all you're going to hear today. And the interventions were botulinum toxin injection perioperatively, meaning up to 1 month before or during the actual procedure, and surgery on a spastic limb for any purpose. The controls we're looking for any RCT would be no botulinum toxin injection or normal saline or no other intervention. And the outcomes I've listed here with regards to surgical success, failure, and looking at pain, spasticity, range of motion, positioning, and overall quality of life. So we identified, it's a busy slide, but we identified 184 full-text articles excluded, 191 included initially, and then we excluded 184. We use the keyword spasticity, toxin, and surgery, and we use a PRISMA guidelines for the systematic review. And we found 7 articles, 2 randomized control studies, 1 retrospective, 1 case report, 1 letter to the editor, and 2 that we're likely going to accept for the systematic review that are randomized control studies. So let me outline some of the studies that have made us think about perioperative toxin. So this is a study by Metcalf et al. In Journal of Hand Microsurgery in 2015. He was looking at uses of toxin preoperative to help improve outcomes in cerebral palsy neuro-orthopedic procedures. It was a letter to the editor, but very interesting commentary about how the toxin should work and can work in neuroorthopedics. So the case that was presented was a 16-year-old with cerebral palsy. She had a left FCR, flexor carpi radialis, to ECRL tendon transfer with releases of flexor digitorum superficialis and flexor pollicis longus. These injections were guided for toxin injection by ultrasound, and they were done 2 weeks preoperatively to FCR, FDS, FDP, and FPL. And each muscle group was injected 50 units of onabotulinum toxin per muscle. They allowed 2 weeks delay before they could actually do the surgery. And the reason, they said, to exert the full effect of the toxin and achieve maximum preoperative reduction in muscle tension. They concluded that toxin was valuable when used in conjunction as an adjunct with tendon lengthening and tendon transfer techniques, and they felt that a combination of surgery and injections produced a synergistic effect. And they went on to argue, and this is a little bit on the research that we've done as well, that manipulation of the muscle tendon unit, and in this case, FDS and FPL, was made easier by preoperative injection of botulinum toxin, as the muscle tendon complex was less stiff, as we saw in the Manava rat model. And also, reduced muscle tension made the surgeon intraoperatively to actually get a better position. That also in their clinic, they've been doing this as a standard of care that can help better position as an outcome post-surgery. So the achievement of optimum tendon length and hand positioning were key, and was a more straightforward process if they did perioperative. Round of applause to all the amazing speech and discussions today.